What if I told you quality of life has nothing to do with bingo, sing-alongs, or even being clean and well fed? Today's guest doesn't hold back, and she's about to challenge everything you think you know about senior care. Let's go.
Welcome to From Leads to Leases, a CCR growth podcast that helps senior living providers transform their complex challenges into opportunities. Listen in for stories from industry leaders, innovative strategies, and insights. And with our expertise, learn how to increase occupancy faster, guaranteed.
Hey everyone, welcome back to another episode of From Leads to Leases, the podcast that dives deep into the senior living and senior care industries, bringing you insights, strategies, and stories from the experts at the forefront of innovation, leadership, and care. I'm your host, Jerry Vinci, CEO of CCR Growth. For those of you who don't know about us, CCR Growth is a full-service marketing and growth agency that's exclusive to the senior living industry. Through this podcast, I'm here to guide you through the evolving landscape of senior care, exploring the innovations, strategies, and leadership insights that are shaping the future of the industry. Whether you're a provider, a caregiver, or industry leader, this show is here to help you make informed decisions and create meaningful impact. So today's guest is Barbara Speedling, a regulatory compliance and quality of life consultant with decades of experience in long-term care. Known for her no-fluff, deeply honest approach, Barbara is a self-proclaimed quality of life specialist focused on helping professionals and caregivers understand life from the resident's perspective. So she works with organizations across the country on behavioral health, dementia care, staff training, leadership development, and improving the lived experience of residents. So in this episode, as always, we've got a lot to cover, but we are going to dive into why so many providers are getting quality of life completely wrong, the myth of independence in senior living and what it's costing us, and some real solutions for rebuilding trust, improving engagement, and confronting the staffing crisis head on. So Barbara, welcome, and thank you so much for joining us today.
Hi, Jerry. Thank you so much for the invitation to share my thoughts. I always appreciate the opportunity and hope that this will be an informative conversation. I think it's a time to really look at what's happening in long-term care. And as I get closer to that, destination of retirement and those kinds of things, I think a lot about these things.
I think the conversation has come up more and more. People are more aware now about what they want and what they need more than ever from previous generations. So I think it's important that we continue to have these deeper discussions and make sure that everybody's seen and heard. I want to start off just talking about quality of life and redefining that. You called yourself a quality of life specialist, and that was a title that you had created, which I love that story. So I would love for you to share that with our audience. But I'm curious what quality of life means to you and how it's different than what most communities think it means.
First, I just have to preface by saying that I started my career in long-term care quite by chance. I was a musician and just sort of fell into what I was doing. But very early on, I became a consultant, an observer, and a teacher, of sorts. And as I learned through that, I found that my nurse colleagues, because the first firm I was with, I was the only non-nurse in the beginning, and my nurse colleagues, they would judge the quality of life according to how you looked. If you looked good and your clothes were clean and you were well fed, well, then, things were good. But I would, maybe because I started in therapeutic activity, but I would always get the other side of that. The person who, yeah, they ate today, but they didn't like it. And, it's all I can have. And so, yeah, we provide you with certain kinds of things and make sure you have the necessity. But I always look beyond that. And I think that quality of life is not only about the physical things, but it's more about, well, what a friend of mine at 92 used to ask a lot during the pandemic is, but why should I get up? Like, what's the point of that? And that's what I think quality of life is about to me. If you can show me how that shell of wellness is really promoting my liking being here and wanting to do it again tomorrow, you have to have that balance, I think. It's got to be, and it's not just about health. It's about money. It's about relationships. It's about speaking your mind. A lot of elders don't say what they want to say, or a lot of disabled people that are dependent, they don't say what they want to say because they're afraid that you won't help them or
Yeah.
that you'll help them less or in a different sort of way. In a nutshell, that's a long answer, but that's what I think quality of life is, a lot of things. And it's fluid. can be good
Absolutely.
this month, and boy, something happens, and tomorrow it's different.
Yeah, I think absolutely has to be a holistic approach. And then what do you think? How do you think communities are seeing that differently? I mean, are they still stuck in this model of assessing quality of life based on your physical appearance and your overall health, or are they also considering mental health and happiness and all these other factors that you're putting into that equation?
Those things are emerging, but again, they are, the more psychosocial, if you will, aspects of care are emerging as an important thing. But we're stuck in the culture of 65 is a measurement of when life begins and ends. For a lot of people, like just think about the generations before mine. My parents, they waited for 65 because that was the goal to be done. Well, our our
Yeah,
culture
it's true.
thinks that way. What are you gonna do when you retire? Oh, I hear people say, "Oh, nothing." And I think, yeah, for about 24 hours, and then what? So that's part of it. But I think long-term care is still stuck in the physical model of what's good. If it looks good and it doesn't smell bad and you're not complaining, you didn't fall on the floor, well then, we're good. But I meet people because my role has evolved now into clients who've known me for decades, call me and say, "Could you come and figure so and so out? Can you help us see what's going on with them?" And when you sit down, you talk to so and so, they say, "I'm not happy. I can't go outside. I have this alarm on because if you show even a shred of wanting to go on your own somewhere, where you stick a bracelet or an anklet, and every time you go by the door, it's like, oh no, you can't go out." So, I find that those are things that have to change. Communities, senior residences, over 55, these kinds of things. I look at it as another kind of warehousing. We're still putting the other people like sort of over there where we can, you can play bingo, you can go on field trips, but we don't live that way. Is that how you live? I don't live like that.
No, definitely not. And I wouldn't imagine once I hit a certain age, all of a sudden I'm gonna feel like that's the way that I want to live out the rest of my
Right.
life. That's for sure.
You know?
Have you ever, I know you've seen the happiness U curve. I mean, basically your first 18 years, it's up here. And then as you work, through the next 30, 40, 50 years, it's descending
Right.
curve. And then eventually it's supposed to go back up when you hit retirement age. But I think that's kind of where things are misleading because number one, not a lot of people are ready for retirement at 65 financially or just mentally. They're not there. They still have 10, 15, 20 years left where they really feel like they want to contribute. One of the things that you had said last time you talked about was purpose. And I think that's such an important point. And I think that's probably where you can really talk to our audience about where senior living providers are missing that mark because they're not really focused on purpose.
No. Well, again, it's the cultural model of retirement. What do? You
Hmm.
golf, you play bridge, you go to the senior center. Those are all wonderful things, but none of us do that every single day of our lives, and we also don't live in a crowd forever. That's not how people are socialized, and after a while, that familiarity really does breed contempt, and we start arguing and hating each other and all. So productivity gives you back your identity. Part of what I teach when we talk about trauma and grief, I say the biggest traumas that I see as you age are number one, losing yourself to dementia. I mean, just watching yourself fade away and you can't do anything about it. But the other grief is losing who you are. So like in conversation, when you meet somebody new, like at a cocktail thing or some kind of an event, and you say, "Oh, hi, my name is Barbara." And very quickly you get to, "And what do you do?" So if you can't define that anymore, what do you do? It's like when you move into a nursing home and the staff don't mean any disrespect, but they say, "Oh, did you meet the new resident?" And you say, "Well, what do they look like?" "Oh, they're in a wheelchair, they have gray hair, glasses." And then I always say, "And what color is their sweater?" Because that's how I'm going to distinguish them from the next person.
Yeah.
But that's an issue, again, of culture, of looking at people a certain way. I think that when you lose that identity, we could help restore it. Simple. Let me just give you one little example. When I meet a group of people, even if I'm the consultant, I only come once in a while, I would like to talk to all of the retired teachers in one group. Not only am I going to have a common subject matter that even if they have dementia, they're going to be able to contribute to still, if they can still communicate, but they're going to find each other. I just posted something on LinkedIn a couple weeks ago about the fact that I feel we could do more to help people find friends. Residents say to me, well, I know I see these people, but I don't have any friends. And how vital are friends to being in the moment and living and, quality of life. I think productive can be social, but it can also be that need to accomplish something. I don't know about you, but if a whole day goes by and I do absolutely nothing, I sort of feel bad. Like I was lazy, or I could hear my parents in my head, you don't have anything to do. I'll find something for you to do. That was my
Yeah.
upbringing. So a lot of us, I think, in the
Yeah.
boomers are like that too, want to be busy.
I think we lose our identity too. I mean, I have quite a few older adults in my neighborhood, and sometimes I'll ask that question, what do you do for a living? Or and I'll get the response, I'm retired. Okay, so now your identity is just you're retired. Like that's it. That's
Right.
that's the only thing you have going on, So, but I know that's not true. I know they're probably super active. They've got friends, and they're probably engaged in activities, or maybe they're volunteering and doing all sorts of other things, But they don't think to mention that stuff. So I think that's kind of interesting.
But it also tells us that we don't identify with leisure as being
Hmm.
the most important things in our life. And when you get into long-term care, I'm going to tell you from an activities perspective, first of all, the kinds of activities that they offer, you probably don't even really find in the general community. I mean, the kinds of games and things that they make up. I mean, I could tell you all day about silly things I've seen, but that's it, is the focus is on just leisure. And you can only play for so long before you want to work.
One of the things you were talking about just now was the aspect of communal living, and how that's not necessarily something that everyone's akin to being around all the time. And I mean, that is the model right now, right? Is even if it's a smaller community, it's still communal living to some degree.
Right.
What's the other option if that's not the way we're going? Because I know my generation, most of us are introverts. We're not in large groups of people, and nor do we want to be for any given amount of time.
Right. And again, it does cause a lot of problems to have all of
Hmm.
these people on top of each other. Now, if you take like where I'm based in the five boroughs, New York City, most of these homes were built in the 60s and the 70s when nursing homes were just emerging out of what was considered a poor house or the alms homes, those kinds of things. So hallways are narrow. One place in Brooklyn was an old movie theater that was allowed through waivers to be turned into a nursing home. Crazy. Narrow little hallways and five bedded rooms like a hospital ward. Could you imagine living the rest of your life with four other people within a few feet of you forever? I just couldn't see that. The strides that have been made now, though, is that new construction and even some of the refit of these facilities, they have to give you a single room. Like that's always been the argument, is I don't want to live with other people. So you'll see that. You'll also see that as assisted livings are emerging as a new, better long-term care model because they're not exclusively private pay anymore. They've opened up that window. You find that those are previous nursing home buildings that were two or three bedded rooms that they've now turned into an assisted living where you get your own space. However, your meals, anything you want to do socially, there's no real space to get away except in your own room behind a closed door. That has to be a mindset that you really can adjust to. If you've lived like alone or just with your spouse after your children are gone, very difficult adjustment. And I don't think the industry does enough to make sure that you're around people who are in a similar circumstance to yourself. So, for instance, in many long-term care, assisted living, and nursing facilities, you'll find that anyone with a dementia diagnosis, if they don't have a specific environment for that particular group of people, they'll be sprinkled throughout. And there have been assaults and even deaths behind someone with dementia making the mistake of either wandering in on or touching something of somebody else's, and that person responding by beating them up or hurting them in some other way. So I think that this commingling of people has to have more thought to it. And that's something the industry does not do well with. Just like commingling people with chronic mental illness like schizophrenia or bipolar disorder that have volatile reactions, unpredictable, with little people with dementia who are going to annoy them. That's another mistake that I see. And that plays out even in residential apartment kinds of situations, like high-rise buildings, like here in the city. So that's another issue, is that the mental health issues, the commingling of people, more attention needs to be paid. And lately, since the creation of the 988 National Hotline, suicide and mental health, there has been more attention paid to better education, better awareness, but it's going to be a slow learning curve, unfortunately, because dementia is still the primary focus, but dementia is even misunderstood. So I think that that has a lot to do with who you live with. Again, there's a wonderful community in Amsterdam that is designed for dementia. And one of the things they say in a documentary about the place is that, you have to live with people you would choose to live with if you're going to have a quality existence. And
That's a
that's true.
great point.
Yeah. Who would you be friends with? We don't just go, hey, you want to be my
Yeah.
friend? It's not how it
Yeah.
works.
Most people are pretty selective for sure.
Exactly.
Absolutely.
Exactly. Yeah.
One of the things that I enjoy talking with you about is just confronting some of those things that no one else wants to talk about when it comes to this industry. One of those big topics is public distrust. Why don't people trust the long-term care system anymore? And why do you think the industry has earned that distrust?
I think that there has always been a cultural distaste for long-term care. If you look at the evolution, like I said earlier, from the almshouses, the poor houses that were really what people thought about this kind of care. If it wasn't a hospital, then it was something else, that kind of thing. So I think that it started there, that if you, had to place someone in a nursing home, then you were a bad family. You didn't care about them. I heard that in my own family. When my grandmother was 94 and had to be, put into a place where she could be given 24-hour care, my father was really angry about the fact that that had been my suggestion, but it was necessary. So we're living longer, those kinds of things. But the problem I see is that we really haven't evolved in terms of looking at better alternatives. So for instance, as we age and we live longer, medical technology has blossomed. And so now if you're not going to live communally, you're going to have to rely on home care, which is suspect as well because we can't validate what you're doing or whatever. Why else don't we like nursing homes? And my own industry does not like this when I say it, but there is enough public awareness of fraud and abuse that has existed over decades, comes in waves. It's like you can go back to the 70s, the Medicare and Medicaid scandals then. There's been a focus throughout my career on the financial end of it, and not only nursing homes or now assisted livings that are going on to public funding, even hospitals have been accused of billing issues and all of that. So I think the public distrust has been broad, but that the focus on long-term care is both cultural because of the way we view family responsibility. That's one of the things. But I think the pandemic also cemented some of that because we couldn't see you. And
Yeah.
I often ask my audiences, I say, how many of you have children? And they raise their hand, all the people. And I say, how many of you can remember the first time you left your first child with a babysitter, whether it was a family member or somebody else? Oh, the hands go up. I say, did you bring a list of instructions with you? Uh-huh. Did you bring their favorite blanket, binky? Uh-huh. Did you call several times? Uh-huh. So I say, so why don't you expect people to want to know what you're doing with their loved one? And so the pandemic really set us back. We had gained a lot of ground through things like family councils and open education, proactive kinds of things. But now, after the pandemic, unfortunately, we've shifted more to a marketing focus that has looked to kind of repair that, but still hasn't addressed some of the bigger issues, that we see in the paper every day. Like we've got a couple of facilities right now here in New York City and around the country that are going through these attorney general oversight situations where they have to be monitored. And that's public. You never hear the good stuff. You never hear about the
Yeah,
staff
that's
that
true.
bring their own money and they supply people and they buy them presents and they care. You don't hear that, but you always hear about the bad things. So I think it's both a campaign of real public awareness. And I will tell you, in recent conversation with a family group upstate that I was working with, I asked the residents' families, I said, do you ever think that your complaints about the care or the feeling that you have about this place is motivated by your own guilt because you had to place someone? And more than half of the audience said, yeah. So I also think it's a cultural issue that has to be addressed, that it's okay, like we're doing with mental health, that it's okay if somebody's 95 and they really need it's okay. And most of the people that work in these places, they work there because they really want to. It's a difficult job. They're not doing it they're not getting rich doing this. There might be somebody else way up the, chain of command that's benefiting somehow, but the average worker, I know you hear bad stories, but I can tell you that they're doing the job that a lot of people don't want to do. And we should be grateful that there are people who will do this work and do it with dignity.
Yeah, it's definitely not an easy job. One of the other things too I wanted to ask you about in terms of regulations and compliance, I know even some states don't even make that information publicly available so families can research and see if a facility has any marks against them or any negative reports from the past. Is that done by design to give families less transparency into these communities?
I think it's that the information that you are talking about is there for public view, but we don't know it, and people don't know how to access it. I think that's the bigger issue. Speaking for long-term skilled nursing home care, the Centers for Medicare and Medicaid have a site that they call Nursing Home Compare, and I can't speak intelligently whether or not there's a comparable site for assisted living. If not, there's one emerging, I'm sure. But you can go onto the Centers for Medicaid and Medicare site, go to Nursing Home Compare, and you can see their ratings in terms of how many stars up to the 5-star ratings they get. You can see their last several health reviews and what those deficiencies were. And then CMS also publishes every quarter an entire list of nursing homes across the country, their last survey, how they scored, what they were deficient in. So the information is there. I would say that local community organizations, advocacy groups like the state ombudsman's office, and every state has an ombudsman's office, they should be promoting that to their consumers and saying, this is how you access it, this is how you interpret the information, because 5 stars doesn't necessarily mean good in that scale. 5 stars could mean you have too much of something as opposed to someplace else. So I just think that's part of it. The other thing I think is that consumers need to be better at self-research, because there's so much out there through like organizations like AARP and even the departments of health in each of the states or the Attorney General's office site. You can get a lot of information about good and bad and make judgments for yourself. One of the things I wouldn't trust is marketing that people are doing, because, and I've said this again for years, everybody cares. Everybody says we care. I say, but how do you
Absolutely.
care?
Yeah.
Let's define that. So I would get away from that canned kind of approach to how they put themselves out there. I'd be looking for something a little bit more personal, a little bit more, I guess, warm and fuzzy.
And it would be nice if the communities themselves were required to provide that information right on the website. If everybody did, I think there'd be far more transparency and probably less of these types of negative reports floating out there, because they know the families aren't going to do the research. And I've heard so many times families talking about, if I had known that this community had this reputation beforehand, I would have never put my loved one in there.
Right.
So I know they just don't know where to do the research. So that's unfortunate.
I can offer you another intervention that I myself offer here to, people I meet in my community, folks that the church, might call me about. And this is not, again, going to make people in my industry happy, but those who already know me know I do it anyway. But I ride the fence. I do provide educational information, resources to anybody who calls me. So if you're a family member and you're looking for the ins and outs, I even do free conversations at some of the local parishes here. I don't feel that the consumer should have to go through all kinds of, things to get basic information. So like, for instance, when you go into a nursing home and you have your own money, or you go to an assisted living now that accepts Medicaid as well, there's that whole piece about what happens to the money and who does what. There are law firms, elder law firms out there that are, doing this kind of work gratis, offering free seminars. So I think that more people need to get out there and say, you know what, if I'm really going to serve this community, which is my mission, is to really make an impact on the community, then some of it, you've just got to put it out there and you can't worry about the bottom line. Like people say to me all the time, well, how can you do that and still make a living? I say, I don't worry about that. I just do what I got to do. And, the opportunities like something like this present themselves. And then you can go ahead and you can continue to thrive as an individual, a gig worker, if you will, but you can also do a real service to people. And I wish more people with the knowledge would do that. If I tell you what it costs to get someone to sit down with you, some of these planners, it's just ridiculous. People have no money to begin with, and they don't want to give it to you, for information that a lot of us could give you for free.
Yeah.
Just my nature, but I think I could inspire maybe some others to just do a little community service that way.
Yeah. No, that makes total sense. In terms of maybe something else that people don't want to talk about would be, what are the biggest lies we keep telling families and why are they dangerous? And maybe lies isn't the right word. Maybe it's just misconceptions or mistruths, maybe.
And this is a loaded question for me because I don't think that we really set out to deceive you. I think that these facilities feel that what they offer you is great. Okay? What more could you want? Someone is going to bring you 3 meals a day. However, what they don't say is that those 3 meals a day will rotate on a 3-week cycle. So the third Monday of every month, you're going to get blah, blah, blah. And yes, there are alternates because the law requires that you have to have an alternate choice. But what if you don't like the alternate? Well, then there's a grilled cheese sandwich or peanut butter and jelly, or that's what they don't tell you is yes, you have choice. And I say this publicly, so I'm not ashamed to say it here. I get this or this, but that's not enough. If I go to a restaurant, what do I get? Go to a diner. Oh my goodness, you get a 5-10 page menu. That's choice. Okay. Autonomy. They say you have autonomy. Really? Not really. If you say to them, oh no, I never eat breakfast, they're going to drag you out of bed anyway because the law says there can only be so many hours between breakfast and dinner. So we're going to follow the rules rather than give you choice. I read a care plan in somebody's medical record, true story, and the problem statement that we have to identify said that the man was non-compliant with breakfast time. So I said to the staff, does that mean he'd like to eat breakfast at another time instead of 7:30 a.m.? Yeah, but he can't. I said, why not? Why not? Isn't the kitchen there? I mean, can't you put something in the refrigerator for later? Don't we have a microwave? But, if he does it, then everybody's going to want to do it. I say, well, yeah. Can I do what I want? What if I don't want breakfast? Well, you have to eat breakfast. Well, I don't want breakfast. And these kinds of things go on constantly. So how much autonomy and choice do I really have? Okay, then let's talk about other kinds of things like privacy. They say, well, you have a private room. Yeah. Well, I'm going to tell you what, I could put a great big sign on the door that says, don't come in here, I'll kill you. And you'll come in anyway. I can't lock the door. I can't restrict you from coming in. And you're always going to tell me that you have to check on me. So
Hmm.
that's not real privacy either, and I'm supposed to knock and wait for you to say, come in. A lot of places, they don't do that either. You know what's classic? Knock the air and say it. Knock, knock, knock as I walk in and just open the door. So, and again, they don't do it on purpose. They promise you these things, but the average person is in a hurry. And now we have a staffing issue where if you want some help, we got to get it done because there's a whole list of other people and not enough hands. That's not because we're not hiring enough hands. It's because in a lot of cases, there aren't any hands to hire. And that's true. People don't believe it, but that's true. So privacy, autonomy, choice. I don't know about you, but I shower every day and sometimes twice a day, depending on what I'm doing. A house twice a week, maybe. And then maybe not private. Now, there are places where it's supposed to be private. Maybe there's 2 or 3 stalls and there's curtains,
Hmm.
but because we're a team amongst the staff, we're talking and doing and showering. And if you don't talk as the person being showered, like in a lot of nursing homes, well, we just do our thing while we're having a whole conversation. I mean, so dignity, privacy, control. And I know my colleagues would be screaming right now if they heard this conversation, but they know it's true, which is why they often don't shout me down. Some people have said to me that I applaud you and spank you at the same time. And I'd like to think that that's how it comes across because we are
Yeah.
trying.
Yeah.
But how do you, like some of these facilities here in the city are 500 beds. How do you make it personal for 500 people living under the same roof who don't know each other and can't tolerate a lot of stuff? Like, I don't like noise. I'm going to tell you right now, I don't like noise. If you make a certain kind of noise, I'm going to want to kill you. And that's the other part of it, is just trying to get along with everybody. And if you've lived in a college dorm or something like that, or gone to summer camp, you know what I'm talking about. But could you live in camp or a dorm for the rest of your life and be okay? It's a lot of issues. And then come the real personal issues, like relationships, like cohabitation, like sexuality. One man in Ohio told me that he doesn't allow sex in his place. I said, "Is that in your admission agreement? Because I should really know that before I move in." Like, you can't just hang those things up at the door. And if you are in the throes of an early dementia or some other cognitive issue that interrupts your ability to understand or give, consent, you're just going to act on what feels good. And that becomes, oh my goodness, a whole big thing. Even when people do something as simple as hold hands, they think they know each other. That happens commonly. But not allowed, not even that. And so now, after COVID especially, we don't even offer any affection. And could you live the rest of your life without a hug, with nobody putting their arm around you and saying it's okay? We're very hands off now because of infection control, and because those people that evaluate our work are really hot on, oh, you didn't wash your hands. So people are just not doing that. So I see a lot of issues here that the industry is trying to address, but they're human things that are really hard to accommodate on a large scale. So you were right. The smaller the population, the easier it will be. Like my favorite facility here in New York, unfortunately folded during COVID. They were only 49 beds. And you could make life for people in 49 beds, but I have another client in the city that's 800 beds. How do you do that? So
Yeah.
again, long answer. I'm sorry to your question, but
No, no,
those
I think it's vital to share that information with our audience and just to have that conversation. So it's privacy to a point, it's autonomy to a point. Those things are sprinkled in there, but like you were saying, when you look at the long run, like that menu seems autonomous in the dining hall, but then after the first 3 weeks and it repeats
right,
and repeats and repeats,
right.
then you're in some sort of a loop cycle. So other than calling it privacy or autonomy, I mean, what other words could you use? Because like you said, they're not necessarily not trying. I mean, they're trying their best, but in communal living, there's going to be some sacrifices that people make in terms of their privacy and autonomy.
I think that one of the bigger things that happens, and this has happened throughout my career, the staff, when they are a good, well-oiled machine, when they're a good team and they get the work done, something begins to happen to their focus. And all of a sudden, you see that our focus now is the quality of work life. Are we getting it done? Are we timely? Do we get our breaks in? Is it time to do this? Can we commute? And all of that is important. There has to be a balance, quality of life, quality of work life, but it begins to take over. And the industry knows this. They've said for like since the early 2000s, when the whole culture change movement came in, that was intended to remind us that it's not an institution. It shouldn't be. So the schedules, you don't have to have breakfast at 7:30. You don't have to have this every single day. That has shifted now to wanting to keep the staff happy after COVID because of the retention issues. So I find that that has impacted us, that, the day is now structured more for the staff's convenience, for timing, making sure we can cover all of the things that have to get done, and less about the routine that you're offering that resident. So again, I don't know how to describe that in what you would offer to the person, but to say that within the context of what we have to get done, we're going to try to accommodate your individuality as best we can. That is what the industry is trying to promise now, but we haven't educated the staff enough. The hands-on first line responders, those nursing assistants, those home health care aides, we haven't really helped them to understand how to do that. They have a very limited time. Like the one place I'm in now, that's in one of those situations where they've had some mistakes and they're being monitored. They have to achieve a certain staffing ratio, and that's what the government has put out there. that's really unrealistic in a lot of ways. And so what happens is the pressure of the day, rather than you as the resident, what you might be needing, is about filling those slots of people. And so you find people on the phone all day that could be doing other things, trying to find that warm body so you meet the quota. So there's it's a very complicated time. And I think that that's the bigger issue, is that nobody really knows what we're going to become. And that's the big conversation now. In fact, a lot of these leadership conferences at the state and national levels are about the reinvention of long-term care and where we're headed with that. And don't forget what's going on at, the bigger government level too now, where they're chipping away at funding and jobs and so on, which is bound already to have a bigger impact.
Yeah.
So I don't know what the solution is, except that we have to take a really realistic approach to what we're seeing. And I don't know how fast that's going to happen.
I think, yeah, and the problem's twofold. I mean, the staff education piece that you just talked about is huge, but then you also think about just the staffing piece of it.
Yeah.
I know I was just at Argentum's Public Policy Institute in Washington, D.C., and we were talking about there's 880,000 roughly long-term care workers right now, and by 2040, we need 20 million long-term care workers. I mean, how is that even possible? And then you also think about the fact that there needs to be this extra layer of education that people are not getting now. On top of just staffing up, they also have to educate people to really learn how to provide proper care.
We also have to teach socialness and manners, because in the youngest caregiver, it's a very different culture. Very different culture. I don't see the same kind of compassion and empathy, and maybe it's a lack of maturity. When I was 17, I attempted to be a nursing assistant at the local nursing home. No certification, no real training. It was kind of like being a candy striper. Within, the first shift, I knew that this was not going to be a good thing for me. I wasn't mature enough. I wasn't ready for nakedness. I wasn't ready for bathroom assistance. Nobody really explained to me. In today's world, they learn this stuff, but they learn it in a vacuum. Since COVID, there's a lot less on-site training, or practicums that are going on. You do a lot of virtual stuff. So when they are confronted by a real body with a real person in it that maybe has dementia or mental health problems and is not so nice to you, then they just say, "Oh, hey, I'm not doing it." And that was not the way. That was just not the way to throw your hands up and say, "I can't do this." So I think that in the classroom, the place to begin is by sensitizing people. Now, I try to do that by taking it out of the nursing home. Like, one of the first things I talk about when I'm talking to first line staff is if they've ever planned that once in a lifetime vacation, and people, you can hear them, "Oh yeah, I say, "And didn't you got so excited and you took your time." I said, "Did you ever get there and it wasn't what you expected?" "Oh yeah." "Well, how did you feel?" Well, when you do that, then when you start to talk about the circumstance of not getting what you expected at 90, they go, "Yeah, I can see how that would." So you can't start talking about, "Oh, you should be respectful to your elders, blah, blah, blah," unless they can get to a place where they can identify. So like, when I'm talking about people who resist care, and that happens a lot, I say to them, "How old are your children? Or how old were you when somebody told you not to let other people touch you in a certain way?" "Oh, I don't know, 2, 3." "Yeah." Well, when I regress in my dementia, I'm going to remember that. So if you're going to try to take my underwear off, I'm going to punch you. And they should know that. And when you explain it that way, they go, "Yeah, I can see what, yeah. So you better tell them before you do that." There's a way to make sense with people. And I don't think it's rocket science. I think it's a matter of stepping out of academia and into the real world and learning how to talk to people. Like, most people say to me that my lectures are effective because they're common sense discussion. Like, I'm not a nurse, but I can make you think I am because I've learned a lot. I didn't start out that way, but I'm pretty smart now. Just like I'm not a psychologist or a social worker, but I can make you think I am. And that's what the conversation does for everybody, is they walk away, no matter who they are, and they'll say to me 10 years later, "Barbara, I never forgot what you said about coffee, because I talk about that as a trigger for behavior. I say, if you love coffee and somebody walks in with coffee that smells a lot better than yours and probably tastes better and is hotter, then you're going to want that coffee or you're going to hate that person, and that's true. And people go, oh, yeah. Then I ask them if they've been on a diet. I say, you ever see somebody eating something you really want when you're on a diet? Yeah.
Oh
Well,
yeah,
maybe do
that's
you
the
hate
worst.
them? Yeah. You want them to drop it on the floor so you can step on it? Yeah. Well, how do you think those residents feel when you walk through with McDonald's or something else and they're getting chicken again, and they don't
Uh,
even want it? So that makes the audience sit up and pay attention. And I have made a reputation on talking very plainly about things like that make sense.
what would be some simple changes that staff can make in how they speak to residents?
Well, first thing, drop the romper room tone. Talking to you in this tone of voice, you can often hear people go, good morning, and all of a sudden it changes. Don't talk to me like that. That's like that romper room voice. I don't want to hear that. When you ask me, how are you? Wait for the answer, because we don't. We walk down the hall, we go, good morning, how are you? Good morning, hey, come on. And we never wait. We never wait to find out, because if you say, well, not so good, then I have to wait and I have to find out why. And most times people will say, I don't have time to talk to these people. But that's what the people really want is that. I've challenged a few places now to do something for their staff. I give them two challenges. I say, one, ask all of your staff to set aside 15 minutes each day. 5 minutes each for 3 different residents. That's all you want from them. 5 minutes of conversation for 3 different people out of their 8 hours. They can give you 15 minutes. So start a campaign like that. Or tell them that once a month, they can have 1 hour out of their job to go spend it with a resident or a group of residents to do whatever they want. Talk with them, have lunch, whatever you want them to do. That begins to change the way we think and feel about what we're doing and the people we're doing it for. 5 minutes of conversation, if you watch a clock, someone like yourself, 5 minutes is a long time, especially if someone has difficulty, getting that conversation. But those are small things that would begin to turn the culture, that would begin to show us that there's still somebody in there. Because you know what happens when you walk by and say, good morning, how are you? You don't wait. Eventually people stop talking. They stop trying to answer, and then they begin to implode, so that becomes an issue. And that how you can be isolated in a crowd. Lots of people around you, but so what?
Yeah. Still feel pretty lonely. Absolutely. One of the big areas that you focus on as well is mental illness, aging, and the rising tide of complexity in the space. And I'm curious about this. I've spoken with quite a few professionals in the space about the rising prevalence of mental illness. Do you think that this is it just because we're picking it up earlier now than we were before? Is it more people self-reporting? Is it diet, lack of exercise? I mean, what could be causing more of it to happen now than in the past, in your opinion?
I think it's like a lot of other things like dementia, like autism. We are becoming more aware of what it is. Okay. I think that there are emerging groups of people who are willing to acknowledge that they're affected by it. Like when I lecture on obsessive compulsive disorder, I'm not ashamed to tell you that I am a counter. I count my steps, especially when I'm on the treadmill. I don't know why. Maybe it makes the time go faster, but it soothes me to count, and I do it. So does that mean I have a mental illness? Well, maybe I have a shred of something that wires me differently than than you're wired. Depression, I think, is episodic. I think it is reactive. And I think that we are recognizing growing numbers of depression, especially in aging people, because we're living longer. We're living past our expectations. I know that I got to past retirement age too fast. Like, I don't know how this happened, that I'm here already. And I'm going, wait a minute, let me go back now 20 years and start over again, because I didn't exactly plan the way I should have. But I think that's happening. And I know for myself that the question of what my future will hold, like you said before, if we don't live with other people, what will the alternative be? I don't know. I live alone right now in New York City by the grace of rent stabilization. Okay, been in my apartment a long, long time. So I think that, that's another hurdle is, the isolation brings on certain kinds of issues, but, living all together brings on certain kinds of issues. So I think that it's time for the culture to begin thinking about what comes next, and that anxiety will mount as long as we don't know what happens next. And I see that in a lot of elders that I'm meeting in my own community. One that I am now responsible for in some regard. She has no family and I'm her healthcare agent. She'll be 88 this month and she's watching her pennies. Not that she's not set up, but that anxiety, the depression of being alone. She's one of those people that goes out once every other week to the senior group, but the rest of the time she's home by herself. And I see that those things are bringing on more mental health problems. The other thing, and this is a national epidemic too, is that services for people with chronic mental health issues are deteriorating everywhere.
Yeah, that's crazy.
There are no long-term psychiatric beds anymore. Used to be a time, even if you were living in a nursing home and you needed to be stabilized in a real clinical sense, there was a place we could send you while you worked through that, and then you would come back. Those don't even exist anymore. So you know what happens? And again, I'm going to get in trouble for saying this, but those places that are just seeking to fill their beds are not discriminating in the kinds of admissions that they make. So now, especially in long-term skilled care, once I take you, you're mine. I can't return you and say, oops, we made a mistake. So what's happening is that we're filling our beds with people we don't understand, people we're not prepared to care for. We're commingling them with the traditional elder population, which is more than 60% demented at this point in time, and many of whom are duly diagnosed, have a long-standing mental illness, and are now demented. So if we didn't understand schizophrenia before you had dementia, oh my goodness, it's so complicated now. We just don't get it. And therein lies the real liability, is things like altercations between people. And then comes the mistrust. And the reason being is that, the law says at the skilled level that if there is an altercation, even if it's verbal, between the same two people more than once, that's reportable. Do you think people are going to do that every time I call you a name? Do you think they're going to pick up the phone and call the Department of Health and say, oh, well, Helen and John got into it again? But then the burden is keeping Helen and John from ever seeing each other again in the same building. How does that play out? So the law complicates the ability to do some of this stuff too, makes it hard, makes it really hard to achieve an environment like what I talk about is making it livable. Not that it's ever going to be your ideal. Nobody plans on this. That wasn't the end game you wanted. But if you could make it livable, and assisted living approached that, but now assisted living is looking like a nursing home because of aging in place. So I don't know, what those next couple of years are going to bring, but I can tell you that you'll probably see more isolation-related depression because we're opting for elders to go home with home care, and home care still is not the reliable service you would hope it would be, and there's still not the education. So a lot of families complain that home care means the person comes and watches you, but that's not going to keep you thriving. So a lot of that goes on. So again, Jerry, I don't think that there's any real simple answer to the future, except that there has to be appropriate services for each level of complexity. And it should start in your community. We should not be looking to institutionalize people with mental illness. They can thrive in the community if they're well balanced on, between medication and therapy. People can thrive. What you often see is that because we haven't taken care of those people, they end up being homeless. They end up being unstable in their disease process. And then we see them as criminals. And that's a cultural shift that has to occur too. It's a genetic issue. We can't help it. It's organic. And what are you supposed to do about it? And people often associate mental illness with addiction and alcoholism. And that is true to some extent, that people with mental illness do try to self-medicate away these symptoms that nobody seems to be able to manage for them. That usually comes after the mental illness, not as a result of. And that's, again, a public education thing. So a lot of times I encourage my clients to offer free community education. Invite them into your facility. Let them get to see who you are before they need this, and give them education that's going to promote better planning for the future. And maybe we can really then turn the tide. Like there's something called PACE, which are community service organizations that put services back into the community. That kind of stuff has to really grow now going forward. And I don't know how much corporate America that's taking over long-term care is really going to want PACE programs to be the ideal. So there's going to be some of that. You're going to have some competition in what's really best and what the public, I guess, is willing to support.
Yeah, the corporate model wants to institutionalize everyone, and public is actually moving in the opposite direction. That is actually, you mentioned aging in place. That was something I was going to ask you about. So, with Gen Xers and Boomers resisting the communal living model
hmm
and more people wanting to age in place, how do we ensure that home care doesn't become invisible neglect?
Well, I think there are a couple of models out there. Again, if you turn to Europe and to, Holland, you'll see that they are encouraging, college students at the master's and doctorate levels to now commingle and live with elders so that you can live off of each other's, skills and so on. Good situation for the college student who needs an affordable place to live. And in a lot of states, growing states, if you have community Medicaid, they will pay your selected person to actually be your caregiver. So that could work in some communities. I've often said to my friends, in fact, I just went to one of my high school reunions in last year, and we talked about the fact that there's a lot of us women who are single that wouldn't mind moving back to the town we, went to high school in, and we could live together, kind of like the Golden Girls, but with a little, extra care. Like if you needed a housekeeper or you needed an aide, you could hire one who could service everybody. So that way you could live with the people you like, the people you think you would get along with. And I think that that's a model that you're going to see emerge amongst a lot of people my age. I'm looking at 70 soon and I don't plan on retiring. So the only thing that would make me move out of New York City is if I couldn't afford my rent. So the next step for me is not moving out because I don't think I could live anywhere but where I live. The next step would be to look for a roommate situation. And so I think that that's what my generation and the next behind me is going to look at. The other thing I think is you're going to see a regrouping of family. I have an adult niece in her 30s who has already told me that if I want to, I'm welcome to come and live with them. They would even extend their house and build a separate room for me if I wanted that. So I think that families are going to look at options like that. I also think that the public has to do more to look at housing. Lots of seniors, thankfully, I can keep working, but there are many who can't, and they are on that fixed income. If you consider women who are now in their 80s, who are still living at home, like my friend that I was talking about, who don't have any savings or pension because they didn't work outside the home, we need to think about them. We need to stop saying, well, the nursing home is the place for them, or now the assisted living that takes Medicaid is the place for them. People want to live with dignity. So just like some states now have these pooled trusts where you don't have to give up all your money to be able to stay in the community, they need to do more of that for groups of people, for certain demographics. Lots of women out there that didn't have a spouse or didn't have pensions or whatever that are going to create, they're going to be the longer living, populations. We have to start thinking, or they're going to be a burden on society. The other thing I think too is that we have to look at, and again, very controversial subject, and I'm not condoning or, panning all of this. I think that we have to look at longevity and the right to die issues that people are talking about. There are so many people living in long-term care that are maintained by mechanical means who are not even aware that they are alive and they can live like that forever. And I think, but why? So more public awareness of advanced directives. I've already told my sister and I've put it in writing. If that ever happens to me, pull the plug. Don't even think about it. Pull the plug. And if you don't do what I want, there are consequences. That's why I put it in writing. So, that's my choice. Others have other choices. But if you don't have those decisions in writing and you haven't designated someone to make those choices for you, we're going to keep you alive forever. Once we put a feeding tube in or we intubate you on a ventilator, you're good for the long haul. And I think that the public has to look at that seriously and give people the right to say, I don't want that. Let me go. There are people, yes, some come back from their cancer diagnosis and it never comes back. But I've watched a couple of friends now where it just recurs again and you have more suffering for another length of time. And are you really living through all of that? I think we have to give people that opportunity. So again, not saying yes or no, But I think that that's up to the individual. And that has a lot to do with choice too, that we don't offer you.
I would bet 60-70% of people don't have any kind of an advanced directive like that. One of the recent statistics that I learned too was like 45% of older adults or even Gen X were planning on relying on the government to pay for their long-term care. And I thought that was a crazy statistic. Living in the time that we're living now, where we're seeing all of these programs being cut, I don't know how anybody even thinks that that's going to be possible.
No, and what they should know is that that's how people end up on the street or in shelters. Because these facilities right now, I can only speak for what goes on right now, and I used to do admissions many years ago. The first thing they look at is what's going on with you and how much it's going to cost us to take care of you. And if you cost too much to take care of, there will not be a bed for you. That's all. And you can, report them all day about, you're sure they had a bed and they said no, and it's you can do that all day long. But I can tell you there's many ways to get by on that. And just to say, you can say, well, we didn't have the appropriate bed. We didn't have the right, gender section available for, we can talk about those things all day long. So it is going to come down to how much it costs to take care of you. So in today's world, in short-term rehab, which is covered by Medicare, much higher, reimbursements. If you are really heavy care, we're taking you. But if you end up after your, 14 or 21 days and you can't go home and you transition to long-term care, well, that's going to be a big burden for us now. And we're going to probably look for discharge planning or to somehow hope to downsize what kinds of things you need. Or like in some places, maybe it's the medications you're on that hold us up from admission because they're very expensive, So there's a lot to that whole piece of finance that's beyond, just who will pay. It's about how much and how long. And, in fact, the Medicare window has just been, kind of squeezed from 21 days to 14. We want you in and out. So a broken hip or leg or whatever, you're there for in terms of rehab, we want it to be quick. And again, I'm going to say this carefully. A lot of times when you transition from that short-term rehab where you have recovered to a great extent into long-term, there's no more rehab. There's no more sustaining that progress, which complicates your future even more, And again, that's something that we've addressed through things like, floor ambulation programs and nursing rehab step down programs. But in the staffing crisis, those things have all but disappeared. So I know it sounds terribly unrealistic that we'll overcome all of these things, but I think there are a lot of smart people working on policy, working to look at how to step back and regroup from all of this and say, what will that future model look like? Different age groups, different socialness. When we talk about cultural competency, everybody thinks that's about language or something like that, but it's not. It's just about having a world view. And again, living in Queens, this borough of Queens, we speak over 160 languages. So I have a world view every day, but most people don't live like that. You probably have a worldview too, where you are, because people come from everywhere, but go to middle America and it's got a long way before they're culturally competent. And so that's going to impact everything too. And we are becoming less tolerant at this point in time. So I don't know what that future is going to hold, but hopefully we'll grow again and have a broader perspective.
I think we have to. It's a problem that's unavoidable and has to be solved some way or another. So I think if enough of us put our minds together and policy does its job, we'll find a solution that'll work. And of course, it's not going to work well for everyone. That's not the way that government works, unfortunately, but we're going to have to come up with some solutions because right now, if you look at those staggering numbers of what's needed in housing, what's needed in staffing, and then staff education and different levels of care, types of facilities or communities or micro communities, like you were talking about, I love that idea of like the communal living like that, where you just move in with a bunch of friends and you have, you pull your resources. I mean, that's brilliant. I can definitely see more of that happening than anything else. And then real quick, I was going to say was with America is becoming so culturally diverse. I think you're going to see more intergenerational homes because that's just the culture that a lot of people were brought up in. My family is from Italy. My wife's family is from Mexico. And we both live in families where taking care of your elders and taking care of your kids is common practice. practice, and I know that that's pretty common for a lot of people across the United States now.
I just want to interject with a point that comes up a lot with workers. Many workers that come from other places that have immigrated here and now work in long-term care, they often will criticize Americans for that reason. And they'll say, well, where I come from, wherever that could be, we take care of. And I say, what you don't understand is we did too, until the world began to change and families began to be separated from one another. Like my father was transferred in 1964 from New York to Ohio, one of the first executives in his group to be transferred rather than just going and training somebody new there and coming back to New York. So I remember we lived in an emerging townhouse community in a suburb of Cleveland where everybody was transferred in by their company, and they'd stay like a year and then they were transferred. Well, that was the breakdown of American culture, taking care of our own, So I don't think that we've become bad people, but the culture of American life, two members working in the family, same with childcare. It just became something you had to look at. So I think that culturally we're going to shift back. I will tell you that what gives me hope is when I talk to the youngest guys in the gym, the early 20 somethings, and I say to them, what is the most important component of your quality of life? The first thing out of their mouth is family. And that was not what I expected and not what the 30 somethings tell me. They talk about money, about cars, about jobs, but those youngest guys that I talk to all say family first. So that tells me that maybe the pandemic did start to turn the tide. It made us get to know our families, spend more time together. Even though we had technology, I still think a lot of people rediscovered their family time. And maybe that'll help us move forward. I also think that the industry itself has tried through redefining certain terminology, like getting away from just the term quality of life and looking at life enrichment, which puts us in the mindset of, we want more out of this than just sitting. The other thing that we could do as a society is more vocational and rehabilitative thinking for people with mental health and substance use issues. Instead of institutionalizing people, let's start to retrain people, re-educate people, make that 12-step program approach something that's not a shameful thing, but things that we should really encourage people to go through those processes. Substance abuse, a lot of times people, they're hopeless, and that's why they're like
Hmm.
that. So mental health, I think, will have to really rise above where it is right now in order for us to really change the way we look at long-term care living. And it goes hand in hand with what we have to do for those who are homeless already. More needs to be done. So many shelters here in the city have closed down in the last 10 years. And what do we expect? Where are the folks going to go? So those things will shape long-term care as well. And the longer we live, like I said, I'll probably work as long as I'm healthy. I'll work as long as I can. Why else? I mean, what else would I do? That's how I look at it. What else would I do? I can only lay on the beach so long.
Well, I think you've acquired so much knowledge in the time that you've spent in this career too. It would be heartbreaking for you to not share it with others. I think that's the value of knowledge acquired is sharing it. The transfer of knowledge through, our peers and other generations that are, going to come after us. I think it's so important that we pass that along.
I appreciate that. And a lot of my colleagues have thought about retiring, but then have said, well, I'd like to stay and keep my hand in it. And they
Yeah.
should. Because if you
Yeah.
have no experience, coming into it now is just overwhelming. You have to know where we were and what we're trying to gain and improve on. You can't start right now because right now is not the great model. It really isn't.
Yeah.
So we need those experiential leaders. And that's something that they're talking about in Washington too, like the American Healthcare Association and the National Association of Business Leaders. They're all talking about the fact that if you have experience, you need to, contribute that as best you can.
I think a lot of us recognize though that this is that moment. This is that time where we do need to pool our resources and we all need to come together collectively to solve one of the biggest problems in this country and in the world right now. Yeah. So I love that. The last question I have for you, something we haven't talked about yet, but something you talk about a lot is caring for the spirit. What does that look like in practical terms and why is it often missing from the conversation?
Oh boy, that's a tough answer too. Well, I think that what I see And remember, most of what I do on site is interview residents. That's mostly what I do, is people want to know how you feel, and somehow they don't find the opportunity to sit down and talk to you about it, and I do. Um, I think that what we miss a lot of times is that there's still somebody in there who doesn't recognize that they're an old person or that they're a disabled person. I don't know if I shared with you, but when I was in college, I drove disability transportation for other students. It was a campus job. I worked for the campus bus service. And that was really where I got my perspective on what is a quality existence. I can remember so vividly several of the people that I drove for the whole time I was there. One guy in particular used to tell the story of how he dove into a quarry at night drunk and broke his neck by diving and hitting the bottom of the quarry. And he talks about those few minutes of consciousness where he knew that he couldn't move and he wondered. And he said, the last thing I thought is well, I'm not going to say what he said, but what a, what I am. And he said, what a last thought to have is okay. But he talked about the fact that even though he was completely paralyzed, that his quality of life was about having friends, being in college, having a future, having a girlfriend. So I said to him, but doesn't it bother you that you could walk before and now you can't? He said, not really. I'm not missing anything. So I think that that's what we miss in the elders. Even when I went to my high school reunion, it was my 50th. And I'm not ashamed to say to you, I get up every morning and I look in the mirror and I think, but I'm no different. Maybe I'm a little bit more worldly. Maybe I'm a little bit more outspoken and more of a risk taker than I was. But basically, I'm the same person. I like what I like. I don't like what I don't like. I'm sarcastic when I'm sarcastic. I am the same person. And that is what we miss. That's the piece that's missing, is we don't reach inside of you and learn who you are. So when I come back to staff that said, can you go and see what's going on? When I come back to them and I say, do you know what she did for a living? They have no idea. I say, well, she was a person who did this or did that. And they'll be like, really? And then they want to know you. So why don't we start that way, wanting to know you? So when you want to know who I am, and there's a lady in my gym who's my contemporary, and she said, I love talking to you because sometimes I wonder if you make this stuff up. She said, you've done so many different things. But I tell her, I say, I think it's a product of my attention deficit, another one, my own little mental health issues, but I have done a lot of things. I ended up working for a temp agency all through college, every break. So I've worked in all kinds of industry, all kinds of things. So yeah, I'm an interested person who likes to live on the edge. I take chances. If you don't know that about me, you can't help me be well. You can't. So you've got to know all those things. And mostly what you have to know is that I started my life out as an artist, and that artist still lives within my soul. And if you miss that, you're going to miss the whole point of my being here. If I can't sing or draw or play the piano or bake or write something, I'm not going to thrive. And that's what we don't know. We don't know those things about you because we only ask simple, stupid questions. And when we ask you what you did for a living, we write down something dumb like sales. So I always say, well, what did he sell? Houses, cars, cow manure. What did he sell? I need to know. But that's what we don't know about you. And if we can get to that, the quality of life will follow. I believe that. And the satisfaction too. If I know that you're just like, 92-year-old guy born in Sicily who's always going to pinch my butt, then I have to know that. And once I know it, I can let you do it and I won't be offended by it because those
Yeah,
days happen. And then I
right.
take away your right to be who you are. We counsel you and we say, don't ever do that again. But he's been doing it all his life. How is he going to stop? He's not. He is who he is. That piece is what we have to capture. So I always tell my audience when in the end, when I move in, they should be afraid of me because I know a lot about them and I'm going to have the hotline number tattooed to my forehead in reverse. So they will know who I am. Yeah.
I love that. I love that.
It's true.
Barbara, thank you so much for such a wonderful conversation. I'm so
Thank
glad you
you.
joined us today and shared all of your knowledge with us. How can our audience connect with you and learn more about your consulting, your speaking? And I think you even have an upcoming book. Is that right?
Yes, hopefully it'll be out sometime this summer. It is
Awesome.
what I hope will take this conversation we've just had to the general public and really help them to understand what they have to do for the future. I have a website. It's simple, barbaraspeedling.com, where you can take a look at the educational topics that I speak on, and there are some examples there of things that I've written about, some on my blog, and how to contact me.
Awesome. Well, when that book comes out, we'll make sure we put the link in our show notes so everybody who's listening to this can grab a copy for themselves. So thank you again. As we wrap up today's episode, I want to extend a huge thank you to Barbara Speedling for joining us and sharing your raw, honest, and incredibly necessary perspective on the future of senior care. From public trust and mental health to quality of life and caregiver training, Barbara doesn't just challenge the status quo, she offers real solutions. So I hope everyone connects with her. If you want to stay connected with Barbara and learn more about her work, visit barbaraspeedling.com, and you can also follow her on LinkedIn. And again, I'll include all of that in the show notes. So as always, we hope you found this episode insightful and inspiring. Don't forget to subscribe to our podcast on your favorite platform and stay tuned for more episodes where we continue to explore the evolving world of senior care, covering everything from innovative care models and leadership strategies to family support, technology, and the future of aging. Also, remember that From Leads to Leases isn't just an audio experience, we're also a video podcast. And if you want to see the video versions of our episodes, you can subscribe on YouTube or Spotify. And please like and share this episode with anyone who might find it useful. So I'm Jerry Vinci, CEO of CCR Growth. Thank you for joining us on From Leads to Leases, and I'm truly grateful for your time and attention. Until next time, lead with strategy and with heart. Chat with you again soon. Thanks, Barbara.
Thank you. Bye.
Thanks for listening to From Leads to Leases. Are you ready to fill your rooms faster and increase occupancy? Visit ccrgrowth.com to learn about our Senior Growth Innovation Suite, a proven system to generate highly qualified, tour-ready leads, accelerate sales, and reduce acquisition costs. Let's connect and turn your challenges into opportunities. See you next time.